So thank you so much for joining me.
Oh, well, thank you, Emma, and I'm happy to be here. Thanks for the opportunity. And I've actually been a fan of your podcast, and I've listened to some of the patient stories. So thank you for what you do for the sleep apnea patients. I feel like
Well,
it's
thanks
really
for
beneficial
listening.
and educational, and it's
Yeah,
it's good for it's good for also the providers to see the patient side of things too, to
yeah.
be able to
I think
empathize and
that I think that's something that I didn't really realize when I started out doing my podcast. I really did it more for patients, but now that I'm 3 years in, there's a lot of dentists and doctors that listen, which I really like. So why don't you start by giving us a little bit of background, just about you and, like, what you do, maybe, like, a little bit about your medical journey and how you ended up
sure.
here?
Sure, yeah, thank you. So I'm born and raised in Houston, Texas, and I went to Baylor University in Waco for my undergraduate education, and I was pre-med there. I was able to attend University of Texas Medical Branch in Galveston for my medical school, and then moved back to Houston, back to my hometown for my ENT surgical training. So I trained at Baylor College of Medicine and the Texas Medical Center, which was the 5 busiest years of my life, but provided great training because they have some of the most world-renowned hospitals there, including MD Anderson, Ben Taub Trauma, Texas Children's Hospital, the biggest VA hospital in the nation is there. So we're able to train at these facilities, which is given me quite a foundation for my experience from a surgical standpoint and just for patient care. And
So
right
what
after,
drew you initially to the ENT
yeah,
space?
I grew up playing sports my whole life, so I kind of assumed I would do orthopedics, and so I did a rotation during medical school, thinking, okay, this is going to be it. And like most things in life, it wasn't what I thought it was going to be when I got in there, and so I really didn't like it as much. And so I knew I wanted to do something surgical, and so I rotated through all the different surgical fields, urology, ophthalmology, and then finally settled on ENT because two main things. One is I can treat patients from all ages. I tell people I treat people from newborn to 100,
Mm.
which keeps it interesting for me. I love treating all ages. The kids are great. I love even the older patients. The stories I get from them are wonderful too. And then the other fact is I like ENT is the variety of the different procedures and surgeries that we do. And any given day, I can do a sleep apnea surgery, a sinus surgery, a tonsillectomy, and I also do vagal nerve implants for epilepsy patients. Like
Mhm.
it's and ear tubes for a kid, a 9-month-old that has recurrent ear infection. So even within any given day, it keeps it interesting for me. There's a lot of variety. The anatomy is very intricate, which I enjoy that aspect of it. It's just cool anatomy, I feel like. And our gross anatomy class,
I can't relate. I'm
yeah,
so glad people like you do your job, but I'm just like, "Oh my goodness,
I do get
nothing
that
about
question
that
a lot.
appeals to
Yeah,
me."
they're like, why ENT? Why boogers, mucus, and wax? Like, why do you
Right.
do it? I say,
It's
well, I like to
awful.
stay above the collarbone. That's what I tell people.
So before this Inspire thing came about, because it's still relatively new, were
Yes.
you treating some sleep apnea patients with other procedures? Like, were you
Yeah.
working on people's noses and doing
Yeah.
tonsillectomies and that kind of thing?
For sure. So the sleep apnea surgery has been on a continuum over years, right? So when I was in residency, the theory at that point was to do multi-level surgery, or we called it bi-level surgery, right? So you need to do something to open up the nose, and you need to do something to open up the throat. Whether and that combination could be a multitude of things, right? So it could
Yeah.
be a osti and a turbinate reduction in the nose, and then a U triple P in the back of the
Yeah.
throat, or a hyoid suspension, or whatever the case may be. Is every patient was different, so we would take them in residency and do a sleep endoscopy.
Yeah.
uh Sleep endoscopy before Inspire was even on the radar.
Yeah.
We would take them and say, all right, where are the levels we need to address? And even with that thought process, and we really thought we were doing our best at the time with the technology that we had. I mean, honestly, and I'll tell patients this all the time, I'm very open and honest about it, is that half those patients we did surgery on and put them through misery for 2+ weeks, half of them, it was a failure. I mean, we didn't
Mhm.
cure, in my estimation, if we're not curing them of their sleep apnea, that in my estimation is not a successful surgery.
Oh
So
my
we were,
gosh. We
so we
can be
were,
best friends.
so we were,
So that'll be a whole thing we'll talk about at some point. From a patient's point of view, surgical success would be I have an AHI under 5, no further treatment necessary. I don't
Yeah,
have to go home and use my CPAP, right? And I think that talking to so many surgeons, a lot of people are still using like the SURE criteria where they're
yeah.
saying, well, we had a reduction in AHI.
Mm,
But to me, it's just much more simple to put it in terms that patients understand, right?
mm.
So
Well,
are
and
you
what I,
looking
what
for,
I sh-
like having to do further things, or are you like
yeah,
helped the problem?
yeah. And years ago, if we got a 50% reduction in AHI during a multi-level surgery, we were patting each other on the back like that was amazing, great job. And but the patients may have gone from an AHI of 40 to 15, but they still need a CPAP. Maybe we lowered their settings on their CPAP a little
Right.
bit, but they're still using a CPAP. That's my point. And
Yeah.
so I was like, there has to be something better, right? That we have to be better. I tell
So
patients,
when did you first hear about Inspire? Tell me about that whole thing.
yeah. So
Like deciding to kind of get involved with that.
so at and I learned about Inspire about 8 years ago, and the rep came and he knew I had been doing a lot of vagal nerve stimulators, which is a very
Hmm.
similar procedure on the other side for epilepsy or seizure disorder patients. And so they thought it would be a natural fit that I could implant their device. And so I went, and I was one of the first surgeons to get trained in doing it. We actually, at that time, Inspire was relatively new to the market. They only had a teaching or educational facility in Atlanta. So my partner and I went out there and got trained on it, did the cadaver dissection, and then he and I started doing them here, and we're in the North Dallas area. And so we were the first to start doing them in the area, and certainly the first in the private practice world. They had started doing a few at UT Southwestern, which is the
Yes.
university here in Dallas. But from a private practice standpoint, that was kind of uncharted waters, which was different because at UT Southwestern, everything's integrated. You have the sleep medicine doctor here, the ENT here, the sleep lab is all
Yeah.
together. So we can talk
Which
more
is
about that.
honestly what you want, right? For everybody to collaborate together.
Exactly. So we've done that here in the private practice community setting world where we have a sleep study we work with, we have a specific sleep medicine doctor that we work with quite a bit, and then us as the surgeons. And we started doing them, and I'll be honest, the research trial, the STAR trial that came out from Inspire, I read it and I was a little bit dubious on whether or not I believed some of those numbers because they were dramatic. They were
Hmm.
dramatic. And I thought, let's see, sometimes the research doesn't correlate to real world, right? And so their research showed that these patients were getting drops of AHIs of 55 to 3. And I talked to Inspire. I said, my partner and I are going to do 10 of them, and let's graph it, and let's see if it matches our first 10. Let's see if it matches the STAR trial, and
Yeah.
then we'll reassess if I'm going to keep doing this or not. And sure enough, our first 10, almost to a T, matched the STAR trial. And so
Wowzers.
I said, all right, let's go. And then we just kind of opened it up. And now our practice, between myself and all of my partners, we've implanted over 250 Inspire patients.
Yeah. So tell me about, I know that oftentimes marketing people have to make things super simple so that people like get this one message. But I think it leads to sometimes a bit of confusion among patients. Like, so patients just get this ad where they're like, okay, it's not CPAP, so I can get rid of my CPAP. But then they don't really know what this procedure is about. So I'm hoping we can
Yeah.
kind of share. So the first thing is it's not for everybody, right? So can you share a
That,
little bit about some of the
sure.
criteria you're looking at for good candidates for this?
So good question. So yeah, part of, we tout our high success rate. And part of that is we've done a lot of them, certainly. And we get, just like with anything, the more you do, the better you get results with it. But it's also patient selection.
Yeah,
I say, look, I'm busy enough as it is. If I'm going to do this surgery and I'm going to make this recommendation, I say, and I'm going to give you a baseball analogy. I said, we're going for a home run here. I'm not going for singles and doubles. We're going for a home run. So if we're going to do this, we're going to go for a home run. And I want to make sure that you're a perfect candidate for it before we move forward. And that's
yeah.
why I have a 94% success rate with these as far as
So
cure.
the
And
success rate to just hammer it home, you're
yeah,
talking about people going from whatever their AHI is to begin with to under 5.
and yeah, and no more CPAP.
No more CPAP.
No more CPAP.
Okay, we can totally agree
Yeah.
on the
So
success rate.
yeah. So
Yeah,
92
that is a really
out of,
high success rate
yeah,
compared to
92
what I've
out
read
of 90.
about. Yeah.
So, and in that, I feel like patient selection is key. And so I actually draw this out for patients on their sleep study. I'll turn it over on the back and I say, look, your AHI is this. AHI stands for apnea hypopnea index, and I go
Hmm.
through the definition and what the categories of normal AHI, mild, moderate, and severe sleep apnea. And I say, okay, you're right here. And I'll talk to him about what's the criteria for Inspire.
Yeah.
Number one is that the AHI has to be between 15 and 65. Okay, that's criteria number one. So if we do that, I'll put a little checkbox by it. Okay, we're
Yep.
good there. Number two, uh, most insurances are still requiring at least a trial of CPAP.
Yes.
Most for 3 months. Different ones will take, some of them are as detailed as they'll see if you actually fill the DME prescription to get the CPAP. You can't just say, yeah, I tried it and it didn't work. They actually will cross check you
Hmm.
on. Just that's a good thing for patients to know too.
Yeah. Are they looking at the data from the CPAP, or they're just looking to check that you had CPAP at all, even
Most
if
of them
you
are just
like
proving
didn't?
that you filled the prescription. Very
Okay.
few I've heard that actually will try to download the data to see if you
Right.
actually for it.
Okay.
I wouldn't put it past insurance companies. I'll
Right.
say that,
Right.
right? But
Yeah.
from what I've heard from patients is that if they've actually filled that durable medical equipment, prescription for the CPAP by
Okay.
3 months later, if they're still not, wanting to proceed with CPAP or BiPAP, then it's clear for us to look at Inspire.
Got it.
The third is the BMI criteria, and that's been a little bit of a moving target. So I want to
So it's
just touch.
changed recently, right?
Exactly. So commercial insurances historically have approved BMI of less than or equal to 32, and Medicare less than or equal to 35.
Okay.
Earlier this year, Inspire got FDA approval to bump that up to BMI of less than or equal to 40 for all carriers. Now,
Okay.
that's great. However, insurances have not recognized that yet. So that's great in theory, but in
Yeah.
a real world setting for patients, it hasn't kicked in through insurance companies yet. And
Okay.
usually, how this process will work is Medicare will usually adopt it first, and then the commercial ones will follow suit a little bit
Yeah.
after.
I mean, that's certainly, I think, with like the criteria for CPAP, I think that's the way that happened. Like, I think
Yeah,
that a lot of the private medical insurance companies, followed what they were doing with Medicare.
once people meet those three criteria, and if they're interested in proceeding, then I talk to them about doing the sleep endoscopy, which is essentially we're reproducing what's happening in their own beds at their home every night. We're doing that medically. So they come in, and I akin it, or my analogy for patients is that it's just an endoscopy, just like you would get like a GI endoscopy without the prep, obviously. But we just come in, the anesthesiologist gives a little bit of propofol just to get you to induce a sleep like state. I put a camera in the nose and I actually record it, and I make sure that the anatomy is sufficient as far as the blockage is actually coming from the back of the tongue. So
Yeah.
you'll actually see the back of the tongue collapse, causing the obstruction. 80% of the time, that's the case, 80 to
Hmm.
90%. However, 10 or 20% of the time, there's something else back there that is resulting in the obstruction. And those are the patients I do not want to put the Inspire in, right?
Got it.
And so
So the
that
ones who are going to do best, you're seeing in your DICE procedure that the tongue is the thing blocking their airway, essentially. So that when you do
pretty
this procedure and it moves the tongue forward, that's going to solve the problem.
exactly.
Whereas if
So
it's somebody who has like a sort of collapsing wet straw, I don't know who it was that described it like that,
yeah,
but like where their airway's actually collapsing in on itself, either because it's tiny or because of like whatever's going on, that's
yeah,
not going to be a great candidate. So we make sure with the DICE procedure that the tongue is the main thing happening.
correct.
And then do you explain all about what exactly happens during the procedure to them?
Yeah. So once we wake the patient up, we submit everything to insurance, including the DICE operative dictated operative report. We send kind of everything to the insurance company that says, look, the patient has met all of your criteria. Here you go. And then usually it takes about 2 or 3 weeks to get approval from insurance companies these days. 4 or 5 years ago, I had some patients take 9 months to get approval.
Yeah, the first person I ever interviewed on the podcast was an Inspire patient, but she did this, I don't know how many years ago, 3 or 4 maybe,
Yeah.
and it took a year.
It's crazy.
But
Yeah.
it's
And
changed a lot, right? So
changed.
people
Well,
aren't.
insurance companies have gotten used to the code because initially any new code with any procedure, sleep apnea or any procedure, insurances will automatically reject those, and those will go to appeal until they get used to seeing those codes come through. So now they're used to it. So
Yeah.
it's a much more streamlined. So after we get approval, we bring the patient in. We'll do a pre-op, and I explained about the surgery. So, it's an outpatient surgery. It takes me about an hour to an hour 15 minutes for it. The patients are able to go home the same day. They have to have a driver, but the actual procedure itself, they're completely asleep under general anesthesia for it. There's two incisions now. It used to be a three incision technique. I know I've seen that
That
on
was
your
going to be my next question.
yeah. Um, so the three incision technique was initially how we did it for about 4 years, and then about 2.5 years ago we switched to the two incision technique, which was great because the patients usually complain most about the third incision because it was lower down between
Kind
the
of by the
ribs.
rib cage. Okay.
Exactly. So you can imagine for that first week or so, every time you turned, rolled over in
Yeah.
bed, coughed, sneezed, that hurt, right? So now we can do it without that incision. And so some of my patients don't even fill the prescription for the post-operative pain meds I send in. I think I would take it for a few days, I tell people, but some of them don't even take it. Like I said, the surgery takes hour to hour 15. And then there's two incisions. Previously was three 5 centimeter incisions, one in the right submandibular region here, right on the jawline, one in the upper chest, and one between the rib cages. Now it's two 4 centimeter incisions. We're actually able to make those a little smaller at the top two here and then here.
So what is it that you're inserting in the chest one? So it's like
Yeah,
it looks almost like a pacemaker, right? But
exactly.
it does
It's
something
a
different.
it's a pacemaker. Inspire calls it a generator. It's essentially a battery, and so the battery sits here in the right upper chest. So we have to make an incision, make a pocket, and actually just make a pocket to have that sit down in there, and we sew it to the pec muscle so it doesn't migrate when patients work out or move or something,
Right.
they're moving around. And then there's two leads that come out of that generator. One goes up to the neck where we hook up to the hypoglossal nerve, which I'll get into, and the other one loops back around and goes in between the ribs right there, and that's called the sense lead.
So it's
So
sensing when people breathe in is what its job is.
And so at night, when you turn it on with the remote, you've seen on all their commercials, I tell patients it looks like a garage door remote, but
Right.
they hold it over the skin to turn it on. And usually there's a latency period. You can adjust Inspire to your specifications, but the default is it kicks on 30 minutes after you turn it on to give you time to go to sleep. And so when you breathe in it at night when you're asleep, your lungs expand. It triggers that sense lead, which starts the whole process. So it sends that signal to the generator, which sends a signal to the hypoglossal nerve because we've dissected the hypoglossal nerve out. We've dissected all the branches out, and I've stimulated all the branches of that hypoglossal nerve. And I figure out with nerve monitoring equipment in the room which one of the branches push the tongue out and
Right.
which ones bring the tongue in. And then you wrap around those branches that push the tongue out only. And
Okay.
so when that signal comes up, it stimulates that hypoglossal nerve, which does two things to the tongue. It flattens it out or stiffens it, and it brings it out by about a centimeter or two. It doesn't have to be much. It's not coming out
You're just
where
clearing the airway.
exactly the tongue rotates forward. So this is the only sleep apnea surgery that we have available to us that we're not cutting anything out. We're actually putting something in, right? And so to move the natural anatomy out of the way, which is the tongue in this situation.
So you have to do some sort of test to make sure you have the right part of the nerve.
So yeah, so we dissect the branches out,
No
and
pressure.
I know there's a nerve probe, and I actually stimulate each of the branches individually. And we have a nerve monitoring technician in the room, and we see the amplitude. And if we're stimulating the hyoglossus or the genioglossus, and you can see it on a tracing, and you say, okay, that's in, that's out. Okay, cuff the ones that we want to put in the cuff, right? The ones that push the tongue out. And so it's and everyone's anatomy is a little bit different, and the hypoglossal nerve has some variability, and you know, it's a very technical surgery. I think it's a fun surgery because the anatomy is interesting, but it is a very technical surgery because those nerve branches are the size of like
Or tiny.
smaller smaller than angel hair pasta. I use magnification glasses to do the
Wow.
procedure.
So once they've done, this is the initial part, right? So they're done with that procedure. They just go home and heal up. And
Exactly. So
then
the
when do they come back? Because then there's going to be like the separate part where you turn it on, right?
I see them back 1 week after the surgery just to check the incisions for healing. And then they come 3 weeks after that, which is a month post op for the activation. And we do it here in my office. One of the Inspire representatives will come and bring the controller, and it connects to the iPad, and we turn it on and test it and then give the initial settings. And they do a full education for the patient regarding how to use the remote, how to turn it up a little bit. They give you a little bit of a range on there. You
Hmm.
can dial it up or down a little bit. And then we have close follow up with them. And then we'll usually wait to do a post op titration study after about 2 or 3 months just to fine tune that setting for them. But they start using it right after we turn it on. I had a gentleman yesterday come in for his activation, and he got to use it for the first time last night. He was really excited.
That's awesome. How long does it take people to find that sweet spot where it's working, but it's not too much it's not too uncomfortable or
Yeah.
whatever?
There's some variability with that with the patients, but I'd say generally it takes about 3 weeks to get super comfortable with it. And I think there's some learning from the muscles and the musculature of the tongue as well to getting used to it as well. Because I feel like the more people use it up front, the faster they improve. If you use it intermittently, your tongue just doesn't know how to handle that, right? And
Yeah.
so the more they use it, the more your body's like, okay, I can get used to this, and the better results they wind up having.
You obviously don't have 100% success rate. So when things happen with this surgery, is it more just that they will still need to use CPAP, or that it's not quite bringing their AHI under 5, or what do you see with that?
Sure. I've had a few that the AHI wasn't quite under 5, and we were able, within the Inspire rep, change settings to get them under that number. So sometimes there can be some tweaks to the settings on the
Mhm.
actual electrodes. The two that I have in my practice that weren't cured, one patient has severe insomnia, and
Mm,
so I have him working with the sleep medicine doc to help us with that, because we can actually download the data from the Inspire to look at when it's used, how long it's used,
yeah,
and it was all over the place. He's trying to sleep like an hour in the afternoon and 3 hours in the evening, and his
yeah,
uh, this this Inspire implant is works best in a setting where you turn it on and you're going to be in bed for at least 6 hours plus.
yeah,
It's not one that you can, all right, I'm going to take a nap here, or catch a cat nap here. It's not good for that situation.
yeah,
My other patient, he wound up having a lot of insomnia issues as well, some PTSD. He's a veteran, and
yeah.
so we're working through
Yeah,
him
I
with.
feel like I don't know how often you come across this, but one of the things I'm really interested in right now is just this for some patients. I think it's this whole thing of sleep where people without sleep apnea sometimes have issues with their sleep. And I think sometimes when people have a diagnosis of sleep apnea, they think all of their sleep issues are to do with the sleep apnea when they're not
Sure,
necessarily. And
exactly.
like sometimes you get into this thing, whether it's CPAP or like they've done an oral appliance or whatever it happens to be, they'll say, well, I'm not sleeping well though, and the doctor's kind
Yeah,
of going, well, I looked at your data, and
it looks
it
fine.
looks
Yeah,
like your medical condition of sleep apnea is really well controlled. And so can that be frustrating sometimes when you're
it
kind of
can.
like looking at the
Yeah,
data?
especially with those two patients, because like I said, I'm pretty selective on which patients I do this to, and so I felt like with those two specifically, their sleep apnea was so bad, it was masking some of this other stuff. So now that their sleep
Yes.
apnea, their numbers look better. I would,
Yes.
but I don't count that as a cure because they're still having trouble, right? So
Right.
their sleep apnea was so severe that, yes, it was masking some of these other issues. And then now that we've got their sleep apnea under control, then we really see, oh wow, like
You
this
start
is a
to
real issue.
unravel the whole
Yeah, yeah. It's
thing.
like the
Yeah.
next layer of the onion. You're like, okay,
Yeah.
now I see what's going on here.
I don't know if you have experience with this, but the powers that be approved using Inspire in Down syndrome, like kids
Yes.
with Down syndrome. Do you do that in your practice, or have you heard anyone
We
that's
have
done that?
yet, and I'm not opposed to doing it. So yeah, FDA approved Inspire implants for Down syndrome patients for ages 13 to 18 is what the FDA approval came through, and their AHI 10 to 50. So
Okay.
a little bit range, and then that age is 13 to 18 approval.
Okay.
There's only been two done in the Dallas Fort
Yeah,
Worth area
it's
so
super
far.
new.
It's relatively new. I've definitely talked to them about being involved with that. We have a new Cook's Children's Hospital close to us, and this could be a huge, huge benefit for Down patients. One of the issues with Down patients is they generally, a lot of them have a larger tongue, and smaller mouth. And so, from an anatomical standpoint, yes, I think it would be extremely beneficial. What we have to be careful with Down syndrome patients is really evaluating that sleep study, because a lot of them will also have a central component as well.
Yes.
And so, we just need to make sure that they're not over that threshold, which is the same threshold for adults, is that the central component of their sleep apnea has to be less than 25%.
So
And
that's
so,
one thing we didn't touch on with the criteria.
yeah,
So if
yeah,
somebody has a mixture of obstructive events and central events, you're going to want to check that they're not over a certain amount.
that's central. Yeah, exactly. So if they're over 25% of their apnea or hypopneas are central, then it just shows that they're not going to do as well, because we're only treating the obstructive component with the Inspire.
Right on. So people are listening to this and they're like, I'm all in. Where do I go? What's the best way to find an experienced surgeon who has done a bunch of Inspire like you if they don't live in Texas?
Sure. It's not feasible to come see myself or my partners who do a lot of these. The Inspire website's actually really good, and hopefully a lot of my patients have looked at that. Maybe a lot of your listeners will as well.
Yeah.
They have Inspire Sleep is the website, but they have a great website, and you can actually go in there, and they have a find a doctor option, and you type in your zip code, and it will populate the doctors in your area that perform the procedure. Now, there are some of those that may pop up, and they may have a little asterisk, or could say like a center of excellence. Those are the physicians or surgeons that do the most of these. We've been lucky enough to partner with the sleep medicine doctor in our area. So our practice and theirs is a center of excellence, which there's less than 10 or 12 in the nation. We're the first in Texas, and certainly the first
Good
private
job.
practice. First private. We've been very blessed with the collegial relationship with another sleep medicine practice that we work with. So, and we've been able, like I said, to replicate what they do at the university, having everyone kind of on the same page, and that's important for this. This is not just a tonsillectomy that I do, or put in ear tubes and, call me
Mm.
if you need me.
So I
This is
guess that's one thing from a patient point of view. We would just love it if all of the people with anything to do with sleep apnea would all be talking to each other all the time. So
yes.
how have you managed to do that? Is it to do with the fact that you're getting referrals from those sleep specialists? People
Mhm.
that haven't done well with CPAP maybe are being sent to you. Or did you go and like knock doors, or how should people be like making those connections?
For sure. For us, it was with a local sleep medicine specialist that was familiar with Inspire, and we met up, and we said, okay, like I said, I have no interest in ordering CPAP supplies, and I'm not going to steal those patients from you. I just said, those ones that are surgically, give me a chance to show you what we can do to help you, and we
Yeah.
really hit it off, and we're able to have that relationship where we're always constantly in communication. Hey, this patient needs follow up. This patient is due for their post op titration study, or hey, I need an updated sleep study, or hey, this patient needs to get adjusted. So we
Yeah.
have that communication, and that's rare in today's healthcare environment, unfortunately, where doctors are talking to each other a lot, right? And
How
so,
do we change that? I mean, I'm just like kind of bashing in and just like trying to change it myself, but I feel like
you know,
maybe there's a larger systemic thing that can happen.
one issue is that we're all kind of operate on an island sometimes, and we need to not be that way, and
Yeah.
that's a physician problem. The other problem is just a systemic problem where everyone is on their own medical system's record. They don't talk to each other. You go to one facility. I mean, I have
Yeah.
privileges at 6 hospitals and facilities around here. Each of them has a different EMR. Each of them has a different password that I have to keep
Yes.
track of. you know
Yeah.
and so I can do something here in my office, and they don't know about it at the hospital, and vice versa. They could do something at the hospital, and then a patient comes and sees me for their pre-op for an Inspire. I'm like, anything changed from your medical history? Like, yeah, I had, you know, I was diagnosed with a cardiac blockage. I had to have a catheterization
Yeah.
last week. I'm, oh my gosh. Like,
Yeah.
you know,
And every single time, so I'm not going to get into like, so I grew up in Scotland, right? So, and we have the National Health Service, which definitely has its problems. But here's what I would say about that. At least it's joined up, right? You
yeah,
have one set of medical records, and every doctor you go to is feeding everything back to your GP. And there's never a question of like that whole thing. Like, I feel like next week I'm having to go in for like a colonoscopy, which I'm not looking forward to. But like,
yeah,
you know, it's like I've never been to a doctor before. They're just
yeah.
asking me all of this stuff, and I'm like,
Same
seriously,
questions.
like it's all
Yeah.
over here on this other system, but
And that's
they
a
don't talk
pain
to each
point.
other, you know?
Yeah, that's a pain point that people feel like they have to give their entire medical history at each visit because the doctor's
Yeah.
communication isn't there, and they're all on different medical record systems.
So if you can think of any ways to solve that, let me know. So is there anything else about the Inspire procedure that we haven't covered? I feel like we talked really well about how you do the initial procedure, but the actual like how it works, like so there's a remote and they turn it on right before they're going to go to sleep. And then that activates this thing where they're breathing in. The sensor you were talking about sends the message that the tongue has to move out of the airway, and they hopefully sleep all night.
Yeah. So
And that's
the
basically it.
yeah, yeah. I mean, that was a good synopsis for sure. So yeah, it times the protrusion of the tongue with the respiration, and that's what it's doing, and in synchrony with that. And so one of the big things is that I tell patients, and I mentioned it, like this is the only sleep apnea surgery that we're not cutting anything out. We're actually putting something in to move your natural anatomy out of the way. And so some people get hung up. Oh, well, I have to have an implant, and I get that too. It's actually more common to have implants than people realize because of people, a lot of people have pacemakers, right? And
Yeah.
so many. And the other question that always patients usually always ask is, Dr. Pahlavan, what happens when I go through airport security? I say, well, they give you a card to show the
Yes.
TSA. And number two, the only time that they actually will see it is in the security. If you go through where you have to put your hands up and they
Yes.
rotate around security, they'll notice it there. And they essentially think it's a pacemaker, just a,
Yeah.
cardiac device.
I feel like when I first
Yeah,
started CPAP 16 years ago, people would be like, "What in the world?" And I'd have to take it
yeah,
out. And now
yeah.
they're just like, "Oh, it's a CPAP," and on
Yeah,
to the next
they
thing.
get it.
So
And
they'll
so
get the same.
the newer version of the Inspire generator or battery, it's approved for most MRIs. That's a question people will give me sometimes if
Oh
they need
yeah,
for other issues. So that's a one that a talking point patients will ask me about sometimes.
yeah.
Um, and
And
then
then the other thing is, and then so at some point they need their battery replaced.
yes, good question. So I haven't had anybody implanted 10 years yet. I think my longest is 6.5, right? So I haven't had to change a battery out yet for Inspire. I changed batteries out for vagal nerve stimulator surgery. I've done, over 100. And that procedure is actually only the chest incision, and you switch out the battery and sew it back up. It's a 20 to 30-minute outpatient procedure.
Okay,
Yeah. Yeah.
and
And
that's
because we leave the neck, the leads, the cuff, all that's the same.
so.
Yeah.
So just really quick. So I guess what I want to know is now that you're doing Inspire, what other surgeries are you still involved with to do with sleep apnea?
I still do tonsillectomies and U triple Ps. That volume has decreased now that I have Inspired,
Okay.
and those patients are much fewer and far between now. But I still do it. I have one tomorrow. I have a U triple P
So
tomorrow.
so I often say that I don't ever hear from people who get sleep apnea, figure out something that works great, and then go about their lives, right? So I'm
Yeah,
only hearing from people that are having a terrible time
it's
or,
trouble. Yeah, I had trouble with.
have been through a lot. But I think with U triple P, what would make a good candidate for that surgery? Because I feel like a lot of them were done back in the day,
Yeah,
and a lot of people didn't see great results, or they saw great results for a short period and then we're dealing with scar tissue and different things, and it wasn't
yeah,
really what they'd hoped. So
yeah.
what kind of people are you doing that procedure on now?
So those are the patients who maybe have mild sleep apnea, maybe in that 5 to 15 range when I examine them, that have either large tonsils and or a low lying palate or enlarged uvula. So if I feel like the oral pharynx is the main issue of the obstruction instead of the tongue, and their AHI is in the 6 to even 16, 17 range, maybe they're at the bottom of the criteria for Inspire, then I
Mhm.
will give that option to them. Because with UPPP, I can usually get the AHI down by 50%. That's what I tell patients. Now, depending on
So if
where
they're
they're starting,
starting fairly low, then
I could
it could
potentially cure them.
be, yeah.
Exactly. And that's my point, is that I would never offer a UPPP to an AHI patient of like 30. Because I like, even though you could have a great surgery, great recovery, I get you to 15, where are we at? We haven't really done much for you. But if
Yeah.
I'm starting at if I'm starting at 9, you know, I think that's a good option. And they have the anatomy on examination that warrants that option, then sure, let's try it.
Well, listen, thank you so much for joining me. I really appreciate it.
Okay. Yeah, thanks for having me.